So please welcome Michael Kidd. All right. Scene is yours.
Tak, Mark. God efter mittag, mina chara kolego. That's it. You'll be glad to know I'll speak in English now, so everybody understands. Thank you for the opportunity to join you today. It's wonderful. Oh, I don't need that one? Oh, good. Yeah, how's that? It's wonderful to see so many colleagues from across Sweden here. This is not my first visit to Sweden or to Stockholm. So I was here nearly 30 years ago when we had the Wonka Europe Regional Conference here in Stockholm. Was anybody at that conference 30 years ago? Yeah, those who are old like me, yeah, we were here. And it was wonderful. The City Hall was there 30 years ago, as was the old city. It hasn't changed. And the president of Wonka 30 years ago was Dr. Goran Schonell, who was the world president for 3 years from Sweden. And I'm told that he's now a pod doctor. So we all move with the times as we get older. And I have been emailing with Goran over the last few days. I came a week early 30 years ago, and it was Midsummer's Eve. And it was such a magical experience for me because I'd never experienced a Nordic midsummer before. The sun went down and then went back up again. The birds went to sleep for about 20 minutes and then they woke up again. And there were Swedish people doing all sorts of unusual things, which I found really, really interesting. On Midsummer's Eve, I was invited to a feast, a dinner, with 12 guests in a friend's apartment here in Stockholm. And we sat around the table. The dinner went for about 5 hours, and we had 12 courses of food. 11 courses were herring. And the last course was a dessert, a cake, baked in the shape of a herring. So it was 12 courses of herring. And with each course, they bring out the course, and we had 12 little glasses in front of us. And each course, they would fill the glass with aquavit, with schnapps of a different sort to match the dish. And then at the end of while we finished eating, someone would have to stand up and sing a drinking song. And then after the end of the song, we would all finish the schnapps. And then the next course would begin. After 8 courses, I could no longer feel my legs, which was unfortunate because after the 10th course, they asked me to stand up and sing a drinking song. And I have no idea what I sang. I can't remember. But it was a wonderful experience. I also visited the Vasa. I got to understand how much, as a nation, you love the sea. And we visited some of the islands in the archipelagos as well, which was really special. I also love the sea. I live in Australia. I live in South Australia. You can see on the map a little circle which shows where we live right on the south coast. The only thing between us and the ocean, on the other side of the ocean, is the South Pole, Antarctica. But this is the view from my home. We live in a little coastal village by the beach. And if you look along the headland, right at the very end is something that we call KI. Now, here in Stockholm, I've discovered when people say KI, they mean the world-renowned Karolinska Institute, KI. But in Australia, KI stands for Kangaroo Island. And it's a beautiful place. I don't know if any of you have been there. It's the second largest island in Australia after Tasmania. And it has its own type of kangaroos. They've been separated from the mainland for so many tens of thousands of years that the kangaroos have evolved. They're much more square and big and muscly than the kangaroos on the mainland. So it's a beautiful place, but that's our version of KI. Here's your version, and I had the opportunity to visit yesterday and hear about a lot of the wonderful research being carried out by Swedish general practitioners across the country, and that was really exciting. So here is our presentation, talking about evidence and practice, bridging the gap in primary care. I was following Maria and Magnus, their talk on Google Translate, so I know what they were saying to you before. And Maria posed a lot of questions that we have as family doctors, as GPs, about using evidence in practice. And I'm going to look at some of those questions. How do we balance evidence-based guidelines with the practical demands we have in providing care to our patients, which can be very complex? And how do we navigate all of the guidelines, many of which are very disease-specific and have been developed using patients in hospitals that don't consider the complexities of our patients and the realities of practice in primary care? So I'm going to try and have a look at how this all works. But I want to start off by looking into the future. My current job involves looking in a crystal ball at where healthcare might go in the next 10 or 20 years. I think we are on about to see a revolution in healthcare due to genomics and genomic science. And I think it's very exciting. My question to you is whether, as we bring more and more genomics into our daily practice, it will actually make guidelines obsolete, that we won't need the guidelines anymore. I'll explain to you why. Once we start doing genomic testing on all of our patients, and this I think will happen sometime over the next decade, you only have to do it once, because your genome does not change throughout your life. It remains the same. So you do it once. That data can go into your health record and then can be used to inform healthcare decision making. And so you do the genomic testing. It provides a one-in-a-lifetime data set about you, about your individual patients, and it will enable us to provide more personalised, lifelong disease prediction and management. And by integrating our genomic data into our clinical decision making, primary care will move beyond these traditional risk models that we've used to enhance disease prediction, which are based on large populations, and will identify for each individual what are their genetic predispositions. We'll be able to develop targeted prevention strategies at both primary and secondary levels. We'll be able to personalise treatment to optimise the efficacy of the care we provide and minimise the side effects. And this transition that I think we're going to see over the next 10 years or so, from population-based recommendations to individualised insights based on people's genome, has the potential to transform the work we do in primary care. It makes it more proactive, it'll make it more precise, it'll make it more preventive, and it will make our role as general practitioners even more important than it is today, because we will be the people who will be helping our patients to navigate what's inside them, what is their genome, and what will this mean for their future healthcare. In a way, I'm kind of glad I'm reaching the point in my career where I'm about to retire and I won't have to worry about this. But in a way, I'm actually really jealous of those of you who are younger colleagues who are going to be able to test this over the coming years and work out how this is going to transform the work we do. But that's the future. In the meantime, we're stuck with what we have. And so what are some of the benefits of the guidelines we currently have in primary care? And what are some of the challenges in developing guidelines that can be useful for our care? And what else awaits us in the future? So let's have a look. This is Voltaire. Voltaire, as I'm sure most of you know, French philosopher, did a lot of writing during the age of the Enlightenment. I looked to see if Voltaire ever visited Sweden, and I couldn't find any evidence, but he wrote a very famous book about the life and times of a Swedish king called Charles or Karl XII. And he regarded King Charles XII as a hero because he stood up to aggression from a very powerful leader in Russia and was a great leader in Swedish opposition to that aggressive power. How history repeats itself over time. But Voltaire, he has a lot of quotes attached to him. My favourite one is his last words. He was on his deathbed, and a priest tried to make him renounce Satan. And Voltaire said, "This is not the time to be making new enemies." And then died. But he also wrote about healthcare, and he was a bit of a smarty pants. Do you know what a smarty pants is? Someone who, thinks they're really clever. He was, but he thought it too. And he said, "The art of medicine consists of amusing the patient while nature cures the disease." That was Voltaire's view. Back in the 1700s, he might have been right, given some of the methods which were being used. But we all know that there's a lot more to what we do than just that, just waiting for nature to do what it does. And as family doctors, as GPs, we need reliable, trusted information to support our decision making so that we can provide our patients with the very best possible care and advice based on what will work for our patient, but also based on the resources that we have available. So where do our clinical practice guidelines come from? Well, in the past, our guidelines came from doctors' practical experience and from the statements we'd heard from our teachers, the people who we looked up to, and from groups of experts coming together and making declarations about what they thought should happen. And do you know who started all of this? Who was the first family doctor to start developing guidance for other family doctors? It was this man, Hippocrates. Back in ancient Greece, 2,500 years ago. Now, my colleagues in other specialties don't like it when I say this, but Hippocrates was a family doctor. He was a generalist. He dealt with everybody. He provided comprehensive care from the cradle to the grave. He really understood the importance of continuity. And he was the first family doctor in the Western world to record his clinical findings and his observations about his individual patients. And he recognised the links between the physical, the psychological, the social and the spiritual aspects of the lives of each of his patients. He was a good GP. And he developed guidance for diagnosis and clinical management. I don't know how many of you have been to the Greek island of Kos, but this is where Hippocrates worked. He worked in a temple. You would enter on the first level and you would buy a chicken or a goat. You would go to the next level and a priest would massacre the chicken or the goat and say some prayers. And then you would go to the third level where you would meet Hippocrates and you would get your care. He specialised in hydrotherapy back 2,500 years ago, which I find fascinating. In the town of Kos is the famous plane tree. Hippocrates sat under this tree with his medical students and taught them. A beautiful place to teach. I don't know if you have a plane tree at your local university where you can go outside and teach your students under a tree, but that's what he did. The tree is still there. It's very ancient. But his guidelines he wrote down in what are called aphorisms, and I wanted to share some of them with you to see if they still work today. Hippocrates wrote that if during an illness there is weeping involuntarily, it is well. But if weeping occurs in spite of oneself, it is bad. And I think what he was describing here is if you have pain and you cry, that's to be expected. But if you don't have any physical symptoms and you're crying, that's a bad thing. And I think he was describing clinical depression back 2,500 years ago. Sudden death is more common in those who are naturally fat than in those who are lean. And again, he was describing coronary events 2,500 years ago before anyone understood what the circulation was and how it worked. It's not enough for a physician to do what's necessary. The patient and their attendants must do their part as well. And the circumstances must be favourable. I kind of like this one. It's all about the patient doing their part and their carers doing their part. But also sometimes there's a bit of good fortune or bad fortune in what happens. Now, some of the things he said have not stood the test of time. It's a sign of madness when blood congeals about a woman's nipples. I have no idea what that is about. If you know, please come and tell me later. For the men in the audience, those whose noses tend to run and whose semen is watery tend to be sickly. I don't know if that's right either. And this one I want to test with all of you. A woman is never ambidextrous. Are there any ambidextrous women in the audience? One? Okay, so Hippocrates, he was almost right. He hadn't met you, but everyone else, he was pretty close. So that's Hippocrates. Since that time, of course, things have evolved, but the goal remains the same. And we want guidelines that are based on the best available evidence to help us with the quality of care we provide, to provide consistent and defensible healthcare, and to lead to better outcomes for our patients, the people who trust us for their medical care and their advice. What's changed in more recent years is the way we develop guidelines. WONCA, the World Organization of Family Doctors, has developed a guide to guidelines. Guidelines that we use should be evidence-based where possible, should be explicit and systematic in the way they're developed, should be inclusive of our patients' preferences and costs. This is one of the fathers of, or the founders of evidence-based medicine, Professor David Sackett, Canadian, who worked at Oxford. And he wrote about what evidence-based medicine is, the conscientious, explicit and judicious use of current best evidence in making decisions about the care of the individual patients. I like that he was talking about the individuals, not about the whole population. And he helped to start the movement that we now embrace in evidence-based medicine. And there are a lot of benefits of evidence-based medicine, EBM, that reinforces the scientific basis of medical care. It places an appropriate emphasis on valid information when we're making decisions with our patients. And it supports the development of clinical guidelines and protocols. So you have research studies and then you use those studies to develop the guidelines and the protocols. And hopefully it improves the quality of the care we're providing year by year by year. But there are some deficits in evidence-based medicine which you can all describe, I'm sure. The evidence may be incomplete. So it may have been carried out in the wrong setting. As Maria was saying, a lot of the evidence that we use is based on research carried out in hospitals rather than in the community where we are based and our patients are based. The evidence may be misleading if it's been developed in a different context. So we may be trying to apply the evidence, but it actually doesn't apply to the patient in front of us. And the evidence may not be as reliable as we need it to be. There are degrees of evidence, gold standard, silver standard, bronze standard, and tin standard evidence, and we've got to be careful with what we use. This is one of my wonderful colleagues at Oxford. You may have heard of her, Professor Trish Greenhoe, and she recently wrote that evidence-based medicine is based on reasoning from populations to the individual. But most patients in primary care don't quite fit the evidence. Evidence-based medicine plays to a vision of logic and certainty, and life is just not like that. So there are benefits to evidence-based medicine, but we need to be careful in how we apply it to individual patients. The challenge is, do we develop guidelines which meet the highest standards of development, or do we develop guidelines with information that can actually be used by clinicians to actually improve outcomes for their patients. I'm sure you've all seen guidelines and thought, I have no idea how I would apply this to the patient who is in front of me here and now. So there needs to be a balance. One-size-fits-all medicine just doesn't work. And we've got to balance according to the patient who is with us. So how do we know if a guideline is any good? Well, there are different groups which have formed ways of assessing guidelines. This is GRADE, which is used very widely. When I was working in Canada before the pandemic, I was on the guidelines committee for the Public Health Association of Canada, and we use GRADE a lot, but it had its challenges because it sifted out a lot of the evidence from settings like primary care. AGREE is another similar group. But whatever we advise our patients, for me it needs to meet the rule of the 3 A's. Whatever we advise needs to actually be available, it needs to be accessible to our patient, and it needs to be affordable to the patient that we have. So some of the guidelines we see, what's being recommended just isn't going to work for our patients. So think of the three A's. Back to Hippocrates. Now, I'm sure some of you understand ancient Greek, but I don't. But Hippocrates' most famous statement is this one: first, do no harm. It's the first dictum of medicine for many of us. So first, do no harm in the care we provide. So guidelines should be there to help us to reduce harm to our patients. The Wonka Guide to Guidelines says that guidelines can cause harm if they perpetuate ineffective or harmful practices. And always look at the date on a guideline, because it may be out of date and it may no longer be current. Guidelines can stifle innovation. They may discourage unconventional approaches to care when what you actually need for a patient is to think outside the box for this particular individual and their care. And it's something we're very good at doing as family doctors, thinking about what will work for this patient. They can provide outdated information if the updating of guidelines is too slow. And they can foster the perception of a loss of clinical autonomy if we feel that we have to follow guideline all the time, rather than stopping and thinking about what should we actually be doing for this patient. There's also the problem of too many guidelines. And we have a challenge in family medicine with information overload, because we are responsible for managing every condition. And so every guideline that's developed, it's why don't the GPs use our guideline? You may never have heard of it, but everyone complains. Guidelines exist for the breadth of clinical issues, and there are new guidelines coming out every single day. So there are literally gazillions of guidelines, leading to guideline fatigue and guideline anxiety. It's a proper condition. I'm sure you've all experienced it. Now, back last century, guidelines used to come in paper form. The GP trainees won't remember this, but some of us will. You'd get the guideline in the mail, and also it would come in journals. And I would keep beside my desk all the guidelines and think, I must read that one and get the information in my head so that I can use it with my patients. And the pile would get bigger and bigger and bigger. And I would start to feel really anxious every time I walked into my consulting room and saw this pile of guidelines that I didn't know about. And the way I relieved my anxiety is I would pick them up and I would put them in the recycle bin, and then I would feel so much better. The anxiety was gone. And my patients may not have benefited from that, but I felt better and was probably a better doctor. There are groups which are developing really good guidelines. NICE is the National Institute for Clinical Excellence in the UK. They have 314 current guidelines on their website. They do warn, though, that while clinical guidelines can help you in your work, they don't replace your knowledge and your skills. So they're not saying put away your knowledge and skills. They're saying this can help to add to it. We have an international guidelines network. Maybe some of you are part of it. Sweden is part of GIN, the Guidelines Network. And their mission is to help us with guidelines. They have in their guideline library links to over 3,000 guidelines. I opened it up. I immediately started to feel that anxiety again from before when I looked at 3,000 guidelines and thought about everything I didn't know. So I closed it and I felt better again. So how do you find the guideline you need? In Australia, the Australian government, we produce our own guideline portal. But the trouble is, often you go in and you look for a guideline and you can't find the guideline for the patient that you're interested in looking for. So it can be very hard to find the information. There's also a problem with the credibility of guidelines, and we've seen this in recent years where conflict of interest arises. And I know you're very careful here in Sweden about avoiding conflict of interest, especially from ties to the pharmaceutical industry. But some of the guidelines are developed by people who are being paid by the people who are making the drugs which are being promoted in the guidelines, and that is a really serious concern. So be careful about what you read. This is Mark Twain. Mark Twain, the American folk author, Tom Sawyer, Huckleberry Finn. He was also a bit of a smarty pants, but he wrote, be very careful about what you read. Be careful about reading health books. You might die of a misprint. And so just be careful about what's there, because he had a point. Who is developing the guidelines that you're trusting? Do they have any conflicts of interest which may invalidate the advice they're providing? We also have governments wanting to have mandatory compliance with guidelines, which threatens our independence as doctors. So there are some policymakers who love guidelines and they would like to turn guidelines into rules to control us. I'm sure that's not the case in Sweden. But it happens elsewhere. So just be very careful. Guidelines are not rules. They're guidelines. They are there to guide us. They're designed to allow us some latitude. So if you have government officials saying it's in the guidelines, you must do it, push back. And you're powerful enough, if you all push back at the one time, no policymaker is going to be able to stand up to the force of it. So push back when it's inappropriate. This is Rich Roberts, my predecessor as the president of Wonka, one of the successors of Goran Chanel, who reminded us that if we want to see evidence-based practice in family medicine, we need practice-based evidence. So we need evidence that comes from our practices, from the work that we do. That's why I was so excited visiting our primary care research colleagues at your KI, not my KI, your KI, seeing the research that they're doing in the community. And that means evidence from family medicine. So are our guidelines based on the right evidence? Paul Glasio, another of my colleagues from Oxford, wrote about the preeminent place of clinical research becoming tainted by methodological shortcomings, by commercial influences, by neglecting the needs of patients and clinicians. We saw this during COVID-19 with some of the preprints. Do you remember this? Some of the preprints which came out on advice on what we should be doing with our patients, which when they were properly peer-reviewed, were found not to be scientifically valid, and that information was taken away. But by that time, the media had got hold of information and was promulgating some recommendations which weren't good. So we need to get better at translational research. If you're early in your career and you're looking at being involved in research, look at translational research as a way of doing your future research. We need to ask the research questions which will provide the answers to the problems that affect our patients. This is one of my heroes, Sir Muir Gray. He's now in his 80s, another professor at Oxford, but he was the Chief Knowledge Officer in the UK National Health Service at the turn of the century. And very wisely he said, in the 19th century, for the health of the public, we needed clear, clean water. in the 21st century, for the health of the public, we need clear, clean information. It's quite nice, isn't it? It's a nice way of thinking about modern public health. We've got the clear, clean water. Now we need clear, clean information. Now, where do our computers come in? You're all using computers, I expect, in your practices, and maybe you have guidelines being presented to you or guidance being presented to you during your consultations. Maybe you turn it off because there's too much which is being presented to you. Again, you get that anxiety from information overload, which can occur. But we now have these clever computer systems. They have electronic decision support tools which are built in to help us to consider and even start to automate some of the implementation of guideline recommendations. Some of those recommendations that may be prompted to you while you're seeing a patient may be based on guidelines and cleverness in your computer system. This development, I thought, was going to happen in the mid-1990s when we started rolling out computers on doctors' desks. It's actually been very slow, but the pace is accelerating. And it may be that artificial intelligence will provide a solution. Now, I know you had some talks about AI this morning, and I'm going to contradict some of that, but just bear with me. Perhaps if we want to know whether AI will provide a solution for family doctors, we should ask AI. Now, 2 years ago, ChatGPT was launched. I was so excited when I heard about ChatGPT. I thought it was an artificial intelligence program for general practitioners or general practitioner trainees, and it was going to transform my life. It actually stands for, do you know what it stands for? Chat Generative Pre-trained Transformer. That's really catchy, but hence we call it ChatGPT. So last night we had a wonderful dinner with the organising committee, who you all saw up here. I then went back to my hotel room. When you're travelling, sometimes, without your loved one, without your dog, it can be a little bit lonely at night time. So what I like to do is charge up my computer and start having a chat with ChatGPT. I know, it sounds a bit sad, doesn't it? So that's what I did last night. Last night I went to ChatGPT to get some advice, and here's how it went. Hi ChatGPT, I'm typing in. Tomorrow I'm speaking with some Swedish GPs about guidelines. Please tell me what you know about artificial intelligence and clinical guidelines for GPs. ChatGPT. AI is increasingly being used to support clinical guidelines for GPs, providing decision support, improving diagnostic accuracy, personalising treatment recommendations, ensuring adherence to best practices. You do wonder what data sources they're going to bring this forward, but it was good. Here's a concise breakdown of how this is actually developing. So this is where it went. Number one, the role of AI in clinical guidelines. AI doesn't replace the clinical guidelines, it augments their use by interpreting complex data, by promoting guideline-based recommendations when you're seeing a patient, by updating clinicians with the latest evidence automatically. That sounds pretty good. Number two, there are tools that support GPs. There are clinical decision support systems built into record systems. There are symptom checkers and triage bots that patients can use. There's natural language processing, which can take data, including if you have an AI scribe running during your consultation, can actually take data from the consultation, turn it into structured actions for your attention. Here's an example. In managing hypertension, AI can compare your patient data against the NICE data or the WHO guidelines, can suggest a specific antihypertensive, no drug company influence here, I'm sure, based on the comorbidities that you're seeing, and it could flag contraindications. And then, however, there are limitations and cautions. There's bias and lack of transparency. Clinical judgment is needed. It complements but doesn't replace your expertise. There are legal and ethical issues in that accountability for the decision you make rests with you, not ChatGPT or any other AI or computer system. And finally, there are some future trends. personalised guidelines as we use genomics. Thank you, ChatGPT, I agree with that, will develop over time. There's real-time learning systems that AI can adapt over time, and we may be able to integrate with national health systems. And this is actually happening in the United Kingdom at the moment, which is piloting AI-assisted pathways in general practice. So would you like some examples of specific AI tools integrated into primary care today? And I said, yes, please, that will be really interesting. I'm sure the audience will be interested. And ChatGPT, but remember, these tools are decision aids. They're not diagnostic authorities. They emphasise alignment with existing clinical guidelines rather than reinventing them. So there's lots of caveats built in here. So here are some of the things that ChatGPT recommended we have a look at, which you may have heard of. Ada Health is a symptom checker that's powered by AI, and can be used by patients to enter their symptoms before they come to visit you, and then provide you as their GP with some structured information to base your decision making on. And it maps symptoms to different conditions using guidelines that are available. So that's an interesting one. IBM Watson, you may have heard of. Watson is not named after Sherlock Holmes' best friend, the GP, Dr. Watson. It's named after someone called Watson who was working at IBM who invented this. But it's for clinicians, and it can assist with diagnosis and treatment by analysing data and matching it with the guidelines. And it is being used quite widely in oncology, which of course is going through really continual, incredible changes to improve care, and is being adapted for primary care. Interestingly, IBM sold it off in 2022, so it may stop working over time. This one is called Isabel Pro. And Isabel Pro is a differential diagnosis generator. Now, I already have a differential diagnosis generator, as you do. It's here. This is my differential diagnosis generator. But Isabel Pro may be able to help by making other suggested diagnoses. And this is EMIS, one of the very popular electronic health records in the UK. You have your own electronic health record systems here, but which is using AI features to promote guideline use, to highlight overuse of overdue investigations or vaccinations, and help with risk stratification. And this is one of the things that you may use and find helpful, or you may turn off. So that's interesting. So that's great, ChatGPT. It's getting late. I feel like I'm really getting to know you well. Can I call you Charlie? ChatGPT says, of course, you can call me Charlie if you'd like. I would like that. And you can call me Michael. Got it, Michael. Pleased to chat with you. I'll go by Charlie from here on. So we're now talking to Charlie. Anything else you'd like to explore before calling it a day? Charlie knew how late it was. So this is good. Yes, what are the risks of AI tools in clinical medicine? Well, Charlie said AI tools in medicine can be dangerous if they're misused, but they're not inherently dangerous, whatever that means. Like any technology, their safety depends on how they were designed, tested, regulated, and used, which we as end users have no idea about. But here's a breakdown of some of the key risks. And it's interesting because Charlie came up with some of the risks that we talked about earlier, about the risks of actually making errors in diagnosis by over-relying on AI, on the bias and inequalities which may be built in, especially inequalities about, does this patient I'm seeing now reflect the patients that the research was carried out on? And usually in family medicine, it doesn't. The risk if we over-rely on ChatGPT or other tools, the risks to data privacy and security. You don't want to enter personal patient details into ChatGPT because you have all of a sudden breached confidentiality. That information goes to the company that owns ChatGPT. I have no idea who that is, where that is, and what that may be used for. But when ChatGPT first came out 2 years ago, hospital residents were putting in patient information to generate discharge information, not realising that they were breaching confidentiality, probably breaking the law in a country like Sweden. And then there's the reliance on outdated or misaligned guidelines. So thanks, ChatGPT. If you're a Swedish GP, would you then rely on artificial intelligence? If I were a Swedish GP, says Charlie, I'd use AI as a support tool, but not rely on it blindly. So what do we come back to? We come to this technology being used as a clinical tool, like a stethoscope or an ophthalmoscope or the investigations that we do. It's a tool, but here's where the decision-making needs to take place. My role as a Swedish GP, says Charlie, using AI would be to augment, not automate. Use it to enhance my own clinical reasoning, not replace it. I'd think of it as a second opinion that works 24/7, but one that needs human oversight. That's actually quite wise, isn't it, coming out of a machine? So we're reaching the end. One more thing before I sign off, Charlie. Can you tell me a medical joke that Swedish GPs might enjoy? Of course, says Charlie. Why did the GP carry a red pen? In case they needed to draw blood. I'm kind of thinking Charlie got his sense of humour from my father, but there you go. That's enough. Say goodbye, Charlie. Charlie says, goodbye, Charlie. We turn him off, and that's goodbye from Charlie, and it's goodbye from me. Thank you all very much. Thank you.